संदीप सर सुरू करें।
करूया का सुरू सर?
हो हो.
नमो नमः. अग्निवेश तद्विद्य संभाषा अग्निवेश तद्विद्य संभाषा ग्रुप की ओर से आयोजित रक्तम जेव इति स्थिति संभाषा में मैं वैद्य संदीप आपका सहर्ष स्वागत करता हूँ. इस संभाषा का आज 10वां सत्र है. पिछले 9 सत्रों में हमने आयुर्वेदीय परिभाषा में रक्त को समझने की कोशिश की. टेक्नोलॉजी की प्रगति ने हमें माइक्रोस्कोप दिया और माइक्रोस्कोप ने रक्त के प्रत्यक्ष का दायरा बढ़ा दिया. ब्लड इन्वेस्टिगेशन में सीबीसी एक प्राथमिक परीक्षण है, लेकिन इस परीक्षण का उचित अर्थ लगाना और निदान के लिए उसका पर्याप्त उपयोग कर पाना वैद्यों के लिए कई बार संभव नहीं हो पाता है. आज इसी कमी को दूर करने के लिए वैद्य रजनीश गाड़ी सर हमें सीबीसी इंटरप्रिटेशन इन क्लिनिकल प्रैक्टिस इस विषय पर मार्गदर्शन करेंगे. प्रथा के अनुसार सर्वप्रथम धन्वंतरि स्तवन होगा.
नमामि धन्वन्तरिमादिदेवं सुरासुरैर्वन्दितपादपद्मम् लोके जरारुग्भयमृत्युनाशनम् धातारमीशं विविधौषधीनाम् शङ्खं चक्रं जलौकां दधदमृतघटं चारुदोर्भिश्चतुर्भिः सूक्ष्मस्वच्छातिरुद्यां शुकपरिविलसन् मौलिमं भोजनेत्रं कालाम्भोदोज्ज्वलाङ्गं कटितटविलसत् चारुपीताम्बराढ्यं वन्दे धन्वन्तरिं तं निखिलगदवना प्रौढदावाग्निलीलम् प्रौढदावाग्निलीलम्.
वैद्य रजनीश गाड़ी सर का अल्प परिचय करवाना मैं अपना सौभाग्य समझता हूँ. जो भी अग्निवेश तद्विद्य संभाषा ग्रुप से जुड़ा है उनके लिए रजनीश गाड़ी सर का परिचय देने की कोई आवश्यकता नहीं है. अग्निवेश ग्रुप पर चल रही चर्चाओं में रजनीश सर अपना सक्रिय सहभाग देते हैं और मार्गदर्शन के लिए हमेशा तत्पर रहते हैं. वैद्य रजनीश सर ने अपना बीएमएस तथा एमडी का चिकित्सा मुंबई के प्रख्यात आर्य पोद्दार शासकीय आयुर्वेद महाविद्यालय से पूरा किया है और वे एमडी के गोल्ड मेडलिस्ट है. कुछ सालों तक उन्होंने दुबई आयुर्वेद महाविद्यालय नालासोपारा में रोग निदान तथा विकृति विज्ञान विभाग में रीडर के तौर पर अध्यापन का भी काम किया है. लेकिन उनका मुख्य परिचय यही है कि वे वसई जिला ठाणे के बहुत ही बिजी प्रैक्टिशनर है और अपने चिकित्सक ज्ञान से कई रोगों का उन्होंने भला किया है. मैं रजनीश सर से अनुरोध करता हूं कि वे हमें मार्गदर्शन करें.
धन्यवाद सभी महानुभावों का and good morning to everyone. First of all, I'd like to thank all of you who are present on this particular meeting and the admin team of the Rakta Jeeva Iti Sthiti group who allowed me to share my thoughts on this particular platform. My today's lecture will be a little bit offbeat as compared to the trend which is going on this particular group, that is the pure Ayurvedic discussion about the Rakta Dhatu. Although one is doing pure Ayurvedic practice, I think one should be thorough and well acquainted with the common investigation reports which are presented to him or her by the patient. And because it helps in the diagnosis and treatment on Ayurvedic terms also. This is my own gut feeling. So the commonest or the most common report which is done, which is prescribed and which is presented to a treating physician in the pathological world is CBC. All of you will agree with this point. The first report which is shown to you by a person or the patient who comes to your clinic is CBC report. It is the most common report which is shown to a physician, and I regret to say that basically it is the most ignored report in the general practice or the clinical practice. Why it is like that, I will just discuss in the future course of our discussion. Hope everybody is getting my voice. Hello?
Yeah, bit louder.
Yeah, hope everybody is getting my voice.
Yes, sir.
Is it all right?
Yes, sir.
Yeah. So what is CBC? CBC literally means complete blood count. Everybody must be knowing all this, the definition of CBC. And in this coming discussion, we'll see what are the different parameters which are included in the most common report which we come across in our day-to-day practice. So today's topic of discussion to me is clinical interpretation of complete blood count. Although I'll try to touch Ayurvedic aspects of this during my lecture, but mostly this lecture will be the pathological interpretation of the CBC reports. And it is not a deep modern medicine. We have come across in your first and second year about the formation of blood cells, their maturity of the blood cells, and how to interpret them. This is just a revamp of all these things which we have learned in the first and second year. Then what exactly the CBC report has inside? We generally see only three things: hemoglobin, white cell count, platelet counts, and we turn off the page and we go in more interesting reports such as sugar, cholesterol, creatinine, proteins, etc., liver function test, kidney function test, etc. But this is most commonly ignored report. This has got at least 15 to 20 parameters which are mentioned on this particular report. The first is red blood cell count. Then the second is hemoglobin, hematocrit, that is the percentage of the blood cells. Then if you specifically ask for, there is a reticulocyte count also. What is reticulocyte count? We'll just discuss in the future course of our discussion. Then it is followed by the RBC indices, which includes the mean corpuscular volume, which is called as MCV, mean corpuscular hemoglobin, then mean corpuscular hemoglobin concentration, and red cell distribution width, RDW, it is in short called that, and which is the most ignored part of the CBC report. This is followed by the white blood cells, which includes a total count of the white blood cells, then the differential count, and any morphological changes which we see in the white cells, which is followed by the platelet count, and finally it is followed by the morphology, cell size, which is mentioned as microcytosis or macrocytosis, then hemoglobin content, which is mentioned as hypochromia, normochromia, anisocytosis, poikilocytosis, and polychromasia. What all these parameters means to us as a clinician, we'll discuss in the future course of our discussion. But before we go into the each parameter interpretation, we just have to revamp or revisit our knowledge about the formation of blood. रक्त धातु की निर्मिति कैसे होती है, ये अपने को जानना बहुत जरूरी है. The first blood cells are formed by a process which is called as hematopoiesis. It is in the process in which the formed elements of the blood are produced. Formed elements of the blood, which are the blood cells, not exactly the only red blood cells. It includes red blood cells, then it includes white blood cells, and it includes the platelets also. The whole blood, as you know, consists of two parts, that the blood cells and as the liquid media, which is called as the serum. Serum is majorly made of water, then the nutritional aspect, then the excretory products and different hormones. It has got other parameters also, other factors also, but discussion about the serum is a topic of another discussion. So we'll not indulge into the that particular part. We'll just concentrate on the cellular part of the blood, which is represented by the common report, which is called as CBC. Hematopoiesis or hemopoiesis, it starts in the early embryonic life at the end of the first trimester. It is at the base of the aorta, the stem cells starts multiplying and they proliferate into the different blood cells. By the end of second trimester and third trimester, the hemopoiesis is majorly taken over by the liver, the spleen and the kidneys. रक्त व स्रोतस का मूल स्थान हम लोगों ने यकृत और प्लीहा बताया है. And by the end of the third trimester, these cells migrate, they occupy, and they start proliferating into the bone marrow. Basically, bone marrow is not the place where the stem cells are originated. Modern medicine has used a particularly specific word. They call it as a niche, N-I-C-H-E. Niche literally means working place or office. So the origin of blood cells or the hemopoietic stem cells is in the liver, in the spleen and the kidneys. रक्तव स्रोतस का मूल स्थान हम लोगों ने यकृत और प्लीहा यही बताया है. इसके साथ अगर वृक्क जोड़ देंगे तो वो भी उसमें आ सकता है. So hemopoiesis starts in the early embryonic life in these particular organs. But in early infancy, after the 3 months, the bone marrow totally takes over the process of hemopoiesis. And except in very rare cases of extramarrow hematopoiesis, which are very, very, very rare, throughout the life, the blood cells are formed, they mature, and they transported back into the circulation only through the blood marrow. There are few pathological conditions, but these are pathological conditions. They are not normal condition. Even though liver, spleen, kidneys, they are responsible for the blood formation in indirect way. They produce the raw material, the hormones which are useful in the formation of blood cells. But throughout the life, bone marrow itself is responsible for the formation of the blood cells. Then I've come across a particular specific word. It is called as erythron. Erythron is an organ responsible for the red cell production, and it is a dynamic organ made up of rapidly proliferating pool of erythroid precursor cells and large mass of mature circulating cells. So erythron is a RBC producing organ, and it is not a static hormone like liver, kidneys. You cannot pinpoint a single organ which is responsible for the production of RBCs. So it is a dynamic organ, and this definition closely correlates with the definition of Raktavaha Srotas or the Srotas, and it is particularly Charakokta Srotasa. The Srotasa is responsible for the transportation of Parinam Apadyaman Dhatu. That is, it is made up where the Dhatu is assembled, it is matured, and it is transported back into its destination place. And Srotas may not be directly linked to the destination place of the Dhatus, but it is the organ, and the ideal word for the Charakokta Srotas, we can call it as a dynamic organ. It is not a static hormone. So somebody asks you where are the Srotas mentioned by the Charaka, you can tell them that erythron, like modern people are saying, the Charakokta Srotasas are the dynamic organs. You cannot pinpoint. They are situated in multiple organs, but at the same time, they are not a static hormone. You cannot pinpoint liver, spleen, kidneys, bone marrow as a specific organ for the production of erythron or the RBC producing organ. Hope I'm clear up to this particular point. Then we'll just have a revamp of the, we'll just go, this is just an academic slide, how the hemopoiesis occur. The hemopoiesis occurs because of the stem cells. Stem cells are present throughout the lifetime of a person, and after a certain age, they tend to decrease in number. You can extract stem cells from an adult person also. The stem cells are all the white cells, blood platelets, and the red blood cells are derived from a single pluripotent hematopoietic stem cell, which differentiates into long-term hemopoietic stem cells, which further differentiates into two lineages, that is common myeloid progenitor cell and common lymphoid progenitor cell. Then the common myeloid progenitor cell further differentiates into granulocytic, monocytic progenitor cells and megakaryocyte and erythrocyte progenitor cells. Granulocytic monocytic progenitor cells further differentiates into monoblast, matures into promonocytes, and finally into monocytes. Monocytes are a part of WBCs, white cells. Then the myeloblast, by myeloblastic lineage, matures into promyelocytes, then myelocytes, then metamyelocytes, and band cells, and finally into the neutrophils. The only difference between the band cells and the neutrophils is the neutrophils have got multi-segmented nucleus. Only maximum 3 to 5 or 5 to 6 segments are seen in a mature neutrophils. But band cells are early or immature neutrophils. They have a bilobe. Only two different parts of the nucleus are cells. And if they are seen in a circulation or in the peripheral smear more than a particular quantity, that means the bone marrow has increased its production and it is transferring this immature white cells because of the demand into the circulation. In another lineage, megakaryocytes and erythrocyte progenitor cells further divides into two lineages, megakaryoblast, then megakaryoblast into megakaryocytes, and finally into the platelets. Then erythrocyte lineage is proerythroblast, basopelic erythroblast, polychromatic erythroblast, and RBCs. RBCs after the maturity does not have nucleus inside. These are one of the cells which does not have nucleus inside into them, mature RBCs. And why? And therefore they are extremely fragile. They do not have nucleus to produce the protein molecules which can help in their repair. So RBCs are fragile. They are not that resilient to the insults. So the most of the time, the causes of hemolysis are these RBC fragility. They do not have a nucleus. And when you see, because the original precursor cell in platelets and RBCs are almost the same, when RBC production is reduced because of certain reasons, the platelet number tend to increase, because if substrate for the maturity of one cell lineage is not available, the other cell lineage, the number increases. Then then the next lineage is common lymphoid progenitor cells, which develops into pro B cells and intermediates, and finally into mature B cells. Some of the B cells, they migrate, and the process called as homing occurs into the thymus, and they are called as T cells, and they are responsible for the memory immunity. Hope I'm clear up to this particular point. Then we'll see each parameter which is given in the red blood cells in the CBC reports. The first one is red blood cells. The usual count is 4 to 5.5 million per cubic millimeters. Red blood cells is the most common cell component of the blood cells. It literally is made up. It literally makes up the total cells of the blood cell component, and the count is 4 to 5.5 million per cubic millimeter. Then the next is hemoglobin. Before we go in details of hemoglobin, I'll just prefer to touch the iron metabolism which occurs inside into the human body. Daily iron requirement in a healthy adult is around 1 milligram, and for that 1 milligram to get absorbed, you should be having at least 15 to 20
विनय सर, रजनीश सरांना फोन करून इन्फॉर्म करा.
करतो. हा, म्यूट झाला रे. अच्छा. बर. ठीक आहे. 2 मिनिटात होते जॉईन. लाईट कनेक्शन ऑफ. जल्दी शुरू होगा. 1-2 मिनट के लिए रुकना होगा. पावर शट डाउन हो गया. अभी बहुत जगह पे इस तरह की दिक्कतें आने शुरू हो गई है, शायद कम बारिश की वजह से होगा। ये नोटिफिकेशन किसका चल रहा है तो कृपया बंद कर दीजिए। नोटिफिकेशन साउंड किसी का मोबाइल में अब भी आया है?
जॉईन झालेत सर.
ठीक है, स्क्रीन दिख रहा है।
हाँ हाँ ऑडिओ कर अनम्यूट. हा ऐकायला येतंय का आता?
तो ऐकायला येतंय, स्क्रीन फुल स्क्रीन पण आहे.
ओके. ते नेहमी असंच होतं, मी सर तुम्हाला सांगितलं होतं. Sorry everybody that there was a disturbances. We come across a lot of power cuts. That's a different issue altogether. I have right now joined with my mobile connectivity and connectivity. Then my voice may get a little bit of cracking in between. So what I'll suggest you that we were discussing about the iron metabolism into the human body. The daily requirement of iron is around 1 milligram per day for a normal healthy adult. And for that 1 milligram to get absorbed, you should be having 15 to 20 milligram of iron in your diet. And when one thing I'll tell you, when you eat, the iron which is absorbed, it is transferred to the spleen and the liver by particular compounds which are called as transferrin molecules. And in the spleen, which are transferred to the reticular endothelial system of the spleen, and these molecules are then converted into the form of ferritin molecules, which are transported back to the liver, where they are recruited into formation of heme part of the hemoglobin, which has got maximum iron inside into that. The other part, which is globin, is these are protein molecules. 4 protein molecules are included in the globin synthesis. There are 2 alpha chains and there are 2 beta chains. Any disruption in this protein formation, this chain formation, gives rise to hemoglobinopathies, and the commonest hemoglobinopathies which we come across in our clinical practice are thalassemias, and the most common is beta minor thalassemias. And so the heme and globin, which are produced as a raw material for the blood cell production, they are transported back to the marrow, where they are assembled into the forms of RBC. Then it is matured, and then it is transported back from the marrow into the circulation. There is one specific condition which everybody may not be aware of, that we do not have iron excretory system. Human body does not have iron excretory system. They have human body recirculates or reutilize the iron. The RBC have got 120 days of lifespan. After this lifespan is made, they are destructed into the spleen. Their iron is reutilized, and it is again repacked into the forms of ferritin molecules, and they are transported back to the liver. So any pathological condition which gives rise to blood loss, that is injury, trauma, or intravascular coagulations, it can cause depletion of the total iron content of the human body. So you can get iron deficiency either by the dietary malnutrition or because of the blood loss. And especially it is true in cases of menstruating females. They tend to lose blood throughout the menstruation time, which is not replenished back, replenished back by the dietary intake. So we'll see how much is the hemoglobin normal values. All of you must be knowing these values. These are taught to us in the first and second year. At birth, the hemoglobin levels are 17. Then childhood, is 12. Then adolescence is 13 grams per deciliter. Adult man, it is 13 to 17. Adult woman menstruating, it is 12 to 15 grams per deciliter. And adult postmenopausal is 13 to 16. And during pregnancy, it is 10 to 14 grams per deciliter. Why it is important to know? Because if you come across the hemoglobin levels in adult menstruating Indian females, very few of them have hemoglobin which is in excess of 12, more than 12, or which is in excess of 12. Most of them are in a status of chronic anemias, and they do not complain about it. They tend to, because this chronicity makes them in a condition where where they consider that this is a normal phenomena, tiredness, weakness, and loss of appetite, and dyspnea on exertion. They consider this is a normal part of their aging process. So any hemoglobin which is less than these particular values, you should consider and start treating that particular patient. They come to know the difference after the target hemoglobin is achieved. Hematocrit is the percentage of blood cells. Hematocrit, they directly correlates with the packed cell volumes. At birth, it is 52, and hemoglobin at the birth is mostly made up of the fetal hemoglobin, which is called as HbF. Then in the childhood, the hemoglobin hematocrit is 36. In adolescence, it is 40. In adult man, it is 47 plus and minus 6. Adult woman menstruating, it is 40 plus and minus 6. Adult woman postmenopausal 42. And during pregnancy, it is considered 37 plus and minus 6 to be normal. What is the importance of hematocrit and hemoglobin we'll discuss in the future course of the discussion. Low hemoglobin is technically called as anemia, and high hemoglobin comes under the terms not erythrocytosis, but they consider under the term of higher hemoglobin or polycythemias. Why they are important? Because low hemoglobin or anemias, they have multiple reasons. We'll discuss if we get a chance in this current topic of discussion. But high hemoglobin or polycythemias, which is hemoglobin more than 17 in an adult person, do not get panicky. Most of the time, the cause is chronic smoking, COPD, chronic lung diseases. If the person is staying in the higher altitude levels, means if you get a person who has directly come from Darjeeling or Uttarakhand, the hemoglobin generally tends to be on the higher side. Then if the person after the chemotherapy has taken any injection which raises, like EPO injections to raise the hemoglobin levels, they can have a higher hemoglobin levels. Hemoglobin levels which are more than 20 is significant. It can cause thrombotic events because of the increased viscosity of the blood. And at that time, the hematocrit is generally more than 60. If the hematocrit is below 60, around 55, just ignore it. Then if you specifically ask for, then reticulocyte count. Reticulocytes are immature RBC produced in the bone marrow. Immature RBCs produced in the bone marrow, released into the peripheral blood, where they mature into RBCs in 1 or 2 days. The increase in the decrease in the reticulocyte count can be indicator of erythropoiesis activity. Normal reticulocyte count is around 0.5 to 2.5%. Why it is important to know the reticulocyte count? Because reticulocytes are immature RBCs. They are called as reticulocytes because they are colored differently after staining, and where the RNA fragments are still seen, and they are premature RBCs. And if their number in a particular blood sample or in the bloodstream are more, that means the marrow is hyper proliferating. The marrow is pushed into producing the more RBCs. This is as a response to the less number of RBCs or response to the anemia. So if reticulocyte count is more, the marrow is functioning well. Then after the reticulocyte, the next parameter which is there is mean corpuscular volume, or in short, it is called as MCV. The mean corpuscular volume is 90 plus or minus 8 femtoliter. The volume tells you about the size of a particular RBC. These are morphological features of the RBCs, MCV, etc. And if the volume is less, that is less than 90 mean corpuscular volume, it is called as microcytosis. And if the volume is more, it is called as macrocytosis. Microcytosis are generally seen in iron deficiency anemias and hemoglobinopathies such as thalassemias. While mean corpuscular volume is raised, that is MCV, that is called as macrocytosis, is a feature of vitamin deficiency anemias. These are basically because of the folate deficiency or cobalamin deficiencies, in which, because of the immature, there is a problem with the maturity of the nucleus and nucleus malformation, the size of the RBCs is much larger. It is also commonly seen in particular leukemias, especially if it is associated with myelodysplasias. Then the second parameter which comes is the mean corpuscular hemoglobin. That is the that is the amount of hemoglobin which is present into a particular RBC. It is called as MCH, and normal value is 30 plus or minus 3 picograms. Why it is important to know the mean corpuscular hemoglobin? Because in iron deficiency anemias, generally the percentage of hemoglobin, corpuscular hemoglobin is less. See, there are only two things. Either the percentage will be less or the percentage will be normal. There cannot be higher hemoglobin in a particular blood cells, because the blood cells cannot store more hemoglobin. They can increase their size, but they cannot store more hemoglobin. So MCH tells you about the hemoglobin content. Either they have low hemoglobin content or normal hemoglobin content. Mean corpuscular hemoglobin concentration closely correlates with the mean corpuscular hemoglobin. And if you understand MCV and MCH, MCHC, that is mean corpuscular hemoglobin concentration, is not that significant parameter. So we'll skip that particular parameter. Then comes a very important factor, that is red cell distribution width, or which is called as RDW. Red cell distribution width is technically a graph, or it's a technically a what you call log representation or percent-wise representation of the size variation in RBCs. If there is a complex mixture of different sizes of RBCs in a given pool of blood, the red cell distribution width, or RDW or RDW's SD, that is standard deviation, tend to increase. So if the blood sample is a mixture of microcytic or normocytic blood cells, the RDW will be much higher. It will be more than 14.5. And the normal value of RDW is 11.4 to 14.5. Why RDW is important? Because this is the most ignored report. If you see hypochromic anemias, hypochromic microcytic anemias, where the size of the RBCs is less and hemoglobin content of the RBCs are less, if the value of RDW is normal or slightly on the lower side, the chances of iron deficiency anemias are very less. There are chances of hemoglobinopathies. That is, most common hemoglobinopathies are sickle cells and thalassemias. And if RDW values, red cell distribution width values, are more than 14.5 or 15, 16, that means the bone marrow is still intact, the hemoglobin formation process is still going on, and that means most probably this is a iron deficiency anemia. So understanding the RDW is of great clinical importance. Then comes the white blood cells. The normal white blood cell count is from 4,000 to 10,000. Anything less, it's called as leukopenia, and anything more is called as leukocytosis. The commonest cause of leukopenias in clinical practice are viral infections. And the commonest cause of leukocytosis in clinical practice are bacterial infection. This is, I'm telling you about the common. There are other relative causes also, which we have to see the differential count to understand what exactly is the cause of each individual white blood cells, increased count or decreased count. Leukocytosis has got features which we call as leukemoid reactions. See, leukocytosis, we tend to see more than 10,000, that is up to 25,000. It's considered to be leukocytosis. But if it is more than that, it is called as leukemosis or leukemoid reactions. Most of the time in clinical practice, leukemia reactions, if it is associated with higher number of neutrophils, it is because of body's response to a bacterial infection most of the time. And they tend to regress back after the infection is covered or controlled by means of medications. But if the leukocyte count is more than 45,000 or 50,000, mostly it will go in favor of leukemias. So interpreting the leukemic white cell count or leukocytosis is very important in the clinical practice. Then the differential count, neutrophils, which constitute the major part of the white cells, comprise of 40 to 80%. The causes of low leukocytes, the low count of neutrophils is most commonly, as I've told you, the viral infections, that is measles, infectious mononucleosis, then malaria also depresses, viral hepatitis, tuberculosis, typhoid also depresses the neutrophil count. Then other common cause is drug induced. Chlorambucil, busulfan, cyclophosphamide, these are alkylating agents which are commonly used as a in chemotherapies, which are, by God's grace, they are not currently using these drugs that often after the invention of tyrosine kinase inhibitors such as imitinib and dasatinib, nilotinib, etc. And methyl dopa is generally used to treat preeclampsia, that is a pregnancy hypertension, and now also it is mostly replaced by labetalol. Then hematological disorders, aplastic anemia, then tumor invasions by leukemic tumors, then myelofibrosis, which is caused, they can cause neutropenias. Then autoimmune disorders, that is rheumatoid arthritis, Weltis syndrome, lupus. Then overwhelming bacterial infections, such as in acute sepsis, can decrease the neutrophil count. And hemodialysis, that is the commonest cause. If your patient is on hemodialysis, regular hemodialysis, you will get neutropenia. You don't have to look for any other cause of neutropenia except it is because of the hemodialysis. Then neutrophilia, if the absolute neutrophil count is on a higher side, most commonly it is because of the infection, that is bacterial infection. Then second cause is inflammations, that is burns, tissue necrosis, myocardial infarction, and pulmonary embolism can give rise to neutrophilia, that is along with leukocytosis. Then myeloid leukemias in early phase are associated with neutrophilia. Then polycythemia vera, that is the higher number, it's a disease where the number of RBCs, WBCs, and platelets increase to a greater extent. Then another important cause of neutrophilia in common, in general practice or routine practice, is stress, excitement, and vigorous exercises. Any person who has recently joined the gym and is doing vigorous exercises, they tend to have a mild neutrophilia along with leukocytosis. And other commonest cause is drugs. Drugs can cause neutrophilia, especially the steroids. Any person who is on steroids can have increased level of white cells in which are predominated by the neutrophils. Then adrenaline rush, adrenaline patient has taken the common painkillers. All the painkillers have potential to increase the neutrophil count. So taking the history of patient while interpreting the CBC report is very important. Lithium is a drug which can cause leukocytosis. Lithium is used for bipolar disorders commonly. Then CSF, that is choline stimulating factor, which is given as a treatment protocol after the chemotherapeutic events. Then metabolic disorders such as ketoacidosis, ARF, eclampsia, acute poisoning, they all can cause higher number of neutrophils, that is neutrophilia. Then the next important cell lineage is lymphocytes. Lymphocytes are reduced, it is called as lymphopenia, in acute bacterial infections, that is tuberculosis, typhoid, acute parasitic infections such as malaria. Then in certain acute viral infections, initial response is of lymphopenia, such as in measles, HBV, that is hepatitis B, hepatitis C. Steroids can cause lymphopenia. Then chemotherapeutic agents, then methotrexate and azathioprine, which are commonly used chemotherapeutic agents, especially in rheumatoid arthritis, and rituximab. Everyone, even if you are doing pure Ayurvedic practice, you should remember this medicine rituximab, because this has become now a gold standard medicine in modern medicine, especially at a higher center to treat the acute cases of rheumatoid arthritis. Autoimmune disorders, then aplastic anemia, lymphoproliferative disorders, then ARF, irritable bowel syndrome, then heart failure, myasthenia, alcohol consumption, stress, and vigorous exercises, they can all cause lymphopenia. Then the causes of lymphocytosis, first is drug-induced allopurinol, which is used in modern medicine for treating gout cases, carbamazepine, then dasatinib. But the most common cause is viral infection. If there is lymphocytosis, the most common cause can be viral infections. Then measles, rubella, common influenza can cause lymphocytosis, cytomegalovirus, Epstein-Barr virus, which can cause infectious mononucleosis. And there is a bacterial infection which is of clinical importance, which can cause leukocytosis with predominant lymphocytosis. That is, number of white cells are more with the dominant lymphocytes. If the patient presents with a history of whooping, history of dry hacking continuous cough, the possibility of pertussis is very high. It is a particular infection which can cause lymphocytosis with total leukocytes, but the count generally in excess of 20,000. Just keep in mind. Then parasitic infections such as toxoplasmosis also can cause lymphocytosis. Malignancies, obviously malignancies will cause lymphocytosis if it is involving the lymphocytic leukemias, lymphomas, Hodgkin's, non-Hodgkin's. Then asplenia, sickle cell disease, and stress, they all cause lymphocytosis. I'll tell you the amount of lymphocytes which are present in the blood circulation are only 20 to 30% of the total body's mass of lymphocytes. Most of the lymphocytes are situated into the lymph nodes or into the spleen. So what is asplenia? That is what you call functional abnormality of the spleen. The spleen is not functioning even if it is anatomically present. So what happens? The homing and the maturity of the B lymphocytes does not occur, and whatever they are stored into the spleen, they are released back into the circulation. So asplenia can cause lymphocytosis, and sickle cell disease indirectly by causing splenic infarction and metabolic asplenia can give rise to lymphocytosis. Then eosinophilia. The third important thing is eosinophils. Eosinophils absolute count is important, not exactly what is given in the percentage. If the absolute count of the eosinophil is more than 500 per microliter, the most common cause in Indian context is parasitic infection, that is helminthic infections. Treat the patient for bumps. Another thing, if the patient is associated with dry hacking cough, which occurs especially at night, it can be a tropical eosinophilia. And otherwise, the other common thing which can cause subclinical allergies can cause eosinophilia. If the patient may not present with itching, pruritus, or urticaria, but they will give you a history of taking medicine. Suppose you get a person a patient who comes to you after consumption of amoxicillin for a fever, which is generally for fever with cough and cold. And if you see slight eosinophilia, most probably the culprit is penicillins or cephalosporins, which he or she might have taken to treat his infections. Then allergic disorders such as urticarias, hay fever, asthma, eczema can show eosinophilia. Then the malignancies such as Hodgkin's, CML, that is chronic myeloid leukemia, then cancers of the lungs, stomach, pancreas, and ovaries, all can cause eosinophilia. But there are particular conditions where the eosinophil count is tremendously high, more than 50,000. I have seen one case where the eosinophil count was approximately 45,000. The case was of eosinophilic leukemia. That was the only case I've seen. And there is another case which is called as Loeffler syndrome, where the eosinophil count is tremendously high. You have to keep it around excess of 40,000, 50,000. In those cases, you are supposed to be more careful because they can cause severe myalgic disorders. When the bone tissue is destroyed, then it can cause endocarditis. So excessive eosinophilia, if you come across, it is always preferable to think on those terms. I have seen one case where there was a port allergy. The person was taking chemotherapy for the treatment of the breast cancer, and there was a port which was pushed inside, which was kept inside for the chemotherapeutic drugs to for the delivery of the chemotherapeutic drugs. And that lady has to have higher eosinophil counts. It was always in excess of 15,000, 20,000, these sort of things. And all the treatments were a failure. And when finally the port was removed, the counts dropped down to normal. So that was a port allergy. So when you see eosinophilia, either parasites, either drug allergies, or any other allergies you should be thinking on. Then monocytes. There are many reasons which I have written here, but they are technical reasons. Monocytes are up to 2 to 10%. For practical purpose, I'll tell you one thing. If you see monocytes which are more than 15%, with the patient giving history of fever with chills or high-grade fever with chills, always think about malaria in our Maharashtra context. If the person is from Bihar or northern side, you can think about Kala Azar, that is visceral leishmaniasis, as a differential diagnosis. And my monocytopenia is generally seen in glucocorticoid space acute infections, but they are of nil clinical significance. Basophils are the least important white cells. Causes of basophilia and causes of basopenia I have mentioned, but only thing which you should remember is that basophilia is seen in hypothyroidism, polycythemia vera, and if there is basopenia, the cause may be hyperthyroidism as well. So with this, we'll complete the differential evaluation of the white cells. Then the next topic which comes is thrombocytes, or which are also called as platelets, which are responsible for the coagulation of the blood. The number of platelets is around 150,000 to 450,000 per cubic millimeter. And most commonly, if the platelet number is less than this, it is called as thrombocytopenia, and if they are more, they are called as thrombocytosis. Most commonly, we come across thrombocytopenias. If the count is more than 1 lakh or 70-80,000 in the setting of cough, cold, throat pain, fever, the cause is generally viral infections. Viral infection suppresses platelet count. But if the count is significantly low, that is less than 60,000, we are supposed to be more careful regarding the evaluation of the patient. And although technically you can do surgeries in which the platelets are above 60,000, but you should be more careful in treating such conditions, and you should ascertain the other bleeding parameters before going for some procedures. If the platelet count drops below 20,000 or 15,000, then it is a significant thrombocytopenia which can cause critical complications. It is generally seen in clinical practice in two illnesses. One is malaria, especially cerebral malaria, which can cause bleeding disorders, DIC, that is disseminated intravascular coagulation, and other, which is more common than malaria, is dengue viral, especially hemorrhagic dengue viral infection. So when you get a patient who has got a history of high-grade fever with headache, retroorbital pain, and who has got low thrombocyte count or low platelets count, you should be thinking on all these two possibilities in your clinical practice. Most of the commonly used drugs, that is ampicillin, lorazepam, amlodipine, even paracetamol, naproxen, mirtazapine, phenytoin, ibuprofen, heparin, ranitidine, all of them can cause thrombocytopenia, that is less number of platelets. But the number of platelets which are depressed in this drug-induced category that is very minimal. You suppose person who comes to you with a history of fever for which is consuming Dolo a lot, you can see the platelets at around say 115,000, 120,000, 130,000, and they reverse back to normalcy when the patient stops taking the medicine. So then generally, if the platelet or thrombocytopenia is caused by the drugs, it is not that gross. I have seen one case of thrombocytopenia, which was a bad thrombocytopenia. The patient's count was 11,000. It was caused by a drug called as leflunomide, and which is commonly used by the rheumatologist. Then immune thrombocytopenia is one of the causes, especially in idiopathic thrombocytopenic purpura and hereditary. Some people, they tend to have lower platelets count. Whatever you do, they tend to have a platelet count which are normal for them. They vary between 90,000, 80,000, 70,000. They never have normal platelet count. And the opposite is thrombocytosis. Thrombocytosis is generally seen as a reaction to the viral infections. Viral infection can suppress, they can cause vice versa, increase in the thrombocytosis. The count which is generally, especially in the child patients, the count is around 6 lakhs, 7 lakhs, and which reverse back to normalcy after the infection gets over. Thrombocytosis is significant when it crosses more than 10 lakhs, and it is generally seen in polycythemia vera conditions. And what happens, can you guess what happens if the thrombocytosis is more than 10 lakhs per cubic millimeter? Contrary to the popular belief, the increased thrombocytes more than 10 lakhs do not cause thrombotic events. They tend to cause bleeding disorders. And the cause is they tend to eat up all von Willebrand factor which is present on the internal lining of the blood vessels. So there is a negative balance which is created. So thrombocytosis, which is more than 10 lakhs, which is significant, will result not in thrombotic events, but it will result in bleeding disorders. And another common cause of thrombocytopenia is pseudothrombocytopenia. You have to ask the pathologist in which bulb they have collected for the CBC interpretation. If the blood is collected in the EDTS bulb, the platelets generally tend to clump together. They are clumped together, and the automatic cell counters, they can count cell to be done. There are 4 or 5 platelets are stuck together. So pseudothrombocytopenia is very common. So you have to see the platelet morphology when you are looking into the whole CBC reports, and you have to ask the pathologist to do a manual count of the thrombocytes when you are little bit worried about the outcome. Then next is cellular morphology, which is written at the last line, which is generally written as a last line. Then the cellular morphology includes the RBC cell size, that is microcytosis, that is a small, the MCV, mean corpuscular volume, is less. It is generally seen in iron deficiencies and thalassemias. Then macrocytosis, which is common in vitamin deficiencies, drug-induced, common methotrexate, etc., which interferes with the nuclear formation in the developing RBCs. Then myelodysplastic syndromes, which are commonly associated with leukemias, both of them can cause macrocytosis. The hemoglobin content, then hypochromic, iron deficiency, thalassemias, normochromic, hemolytic anemias, acute blood loss. Even though the anemia is present, the RBC is normochromic. Anisocytosis is size variations, it's predominant. Means in a given pool of red blood cells, there is a size variation from microcytes to macrocytes to normocytes, then it is called as anisocytosis. Poikilocytosis, it's shape variations. RBCs can change shapes, such as in spirocytosis, they become oval rather than the saucer-shaped RBCs, which are generally we see. Then specific morphological forms are teardrop cells, which are seen in severe vitamin deficiency anemias. Then target cells, where the nucleus is present. Then spur cells, which are seen in renal failure cases. Then sickle cells, morphological variation, which is seen in acute sickle cell crisis. Sickle cell, what happens when the patient is having normal function of the RBCs, unless and until they are exposed to lower oxygen levels or crisis levels. So what happens, the lower oxygen levels tend to crystallize hemoglobin cells or the sickle cell hemoglobins, and they become sickle size, and they are easily destroyed and readily destroyed by the spleen, and they cannot move through the smaller capillaries. They become very stiff. Then the WBC, band cells and abnormal bars and total bodies are seen. Band cells, as we have already discussed, band cells are generally bilobed WBCs, which are premature WBCs. Abnormal blast cells are precursor cells which are seen into the circulation. They are abnormal blast cells are seen in bad leukemias, in leukemic crisis. Then Dole bodies, which are inclusion bodies, which is a sign of acute infections. In platelets, if the platelet formation is stimulated, you can see large platelets, that is megakaryocytes or premature platelets in the circulation, and which is seen as a result of viral infection most of the times. Clumping, as I've already discussed, it is seen if the EDTA bulb is used in normal clinical practice. Then the parasites. Most commonly, parasites which is seen in Indian context are malaria and microfilaria. Microfilaria can cause pulmonary eosinophilia syndromes or filariasis, both they can cause. Then the next slide, which includes, this is generally not included. The Menzer index is generally not included into the routine CBCs, but this is a small calculation which you can do in the clinic also. The ratio of mean corpuscular volume to the RBC count, if it is less than 13, the chances of thalassemias are very high. If they are more than 13, the chances of thalassemias are very less. Person tend to have then iron deficiency anemias. After the basic parameters of CBC, we have covered it up till now. We'll go into the few RBC report, few CBC report interpretations, so that we can sum up whatever we have learned up till now. The first report which we have come across shows hemoglobin which is 4.8% and which has got a low RBC count. The RBC count is 2.22. Then packed cell volume is 16.9, that is also low. Mean corpuscular volume is 76.1, that is low. Mean corpuscular hemoglobin is 21.6, that is low. Then RDW is very high, 20.6. I'll discuss this case. The WBC and platelets are normal. I'll discuss this case in short. The patient is a 76-year-old female. She had a history of atrial fibrillation for which a blood thinner dabigatran was started a few years back. She was continuously taking dabigatran, and the PT-INR tend to be in the target zone. Generally, they require a PT-INR which is slightly more than 2, and the PT-INR was normal. This lady, she had a dark motion since last 2 months, and which she failed to notice, and she thought that it is because of the medicines which she's taking. And one fine day she collapsed, and we have done the test to find that the hemoglobin is pretty low, 4.6. And we have done the iron studies also in this case, and the iron was also very low, 27.5, with the transferrin saturation which was very less, that is 6.8. The transferrin saturation was very less. She was bleeding chronically, and that has resulted in two things. The blood cells were lost, which resulted in the iron deficiency because of the negative iron or the iron depletion, because the iron was not recirculated. It was continuously lost to the blood which was going from her GI system, and on the top of that, she was losing the blood. So this is a mixed case of iron deficiency anemia which was caused by the chronic blood loss. The patient was given 2 pints of blood along with the IV iron, and she recovered in 2-3 days time. The blood thinners was stopped immediately. So this is a typical case of chronic GI blood loss. We have done the stool examination which shows melena with 4+ occult blood and RBCs scattered throughout the stool report. Then the next case is case is of viral infection. This is a case where the hemoglobin is normal, 14.2, WBC count is normal. The lymphocytes are slightly more, 49%, and with thrombocytopenia, 94,000 count is there. The patient had history of cough and cold for 5 days, and this test showed the presence of low platelets, and most probably because of the viral infection. We have done the test after 5 days, which showed a gross recovery after the infection subsided. The next case is a very interesting case. This is a case of already diagnosed case thalassemia minor patient, and this is for the first time in her history. I am seeing the hemoglobin which is around 11%. The RBC count is also very high. See, this is why I'm telling you why all parameters are important to know. Because if you just see the 11 hemoglobin, then the normal WBC count and the normal platelets, you will consider that this is a normal phenomena and you will tend to ignore. But if you see the packed cell volumes, they are also normal. If you see the mean corpuscular volume, it is low. There is a microcytosis. And if you see the mean corpuscular hemoglobin concentration is 19.2. And red cell distribution width is approximately normal. It is slightly higher than 14.5, but it is not very high, which you come across to see. So RBC morphology is chromasia, hypochromic along with microcytic. And when you see hypochromic and microcytic and the hemoglobin is 11 with a normal RBC count, you should scratch your head. And what is the cause? If you calculate the Menzer index, it was around 11 point something. So which correlates clinically with her status of thalassemia minor. So this is the importance of knowing each parameter individually. This is again an interesting case. Hemoglobin is normal. The patient had a history of high-grade fever since 3 to 4 days, very high fever. The hemoglobin is normal. The WBC is slightly depressed with a slightly depressed platelet counts as well. But we have done dengue test and it came positive. Dengue NS1 antigen was positive. So this is a very early dengue. In this patient, after 3 days, the platelet count dropped back to 70 and the WBC count was 2,900. So dengue viral infection can cause leukopenias along with the thrombocytopenias. Then this is again a case of acute viral infection. Hemoglobin parameters are perfectly normal. WBC count is 4,000, 5,200, but relative lymphocytosis you can see. The lymphocytes are increased with a slightly depressed platelet count. This is also a sign of influenza viral infection. Then again, a next slide which tells you about the hemoglobin, that is 7.2%. That is low hemoglobin. This is a gross anemia. The erythrocyte count is normal. Packed cell volume is 27. Mean corpuscular volume is 66.7. Mean corpuscular hemoglobin concentration is 17.6. But the RDW, if you see, it is 20.3. RDW is very high. So it practically rules out the possibility of iron deficiency, rules out the possibility of hemoglobinopathies such as thalassemias. Why? Because in thalassemias, you will not get a higher RDW. That is, red cell distribution width is never on a higher side. 20.3 RDW always means, for practical purpose, iron deficiency anemia. And the leukocyte count was low, 3,300, but it was not, there was no pancytopenia because the platelets were normal. You can see the normal platelets. The iron levels we have done in this patient and it was found to be very low. It was around 10 to 15 as compared to normal values of 50. The next count tells you about eosinophilia. If you see the hemoglobin 15.2, WBC count is normal, neutrophils are slightly on the lower side, platelets normal. If you see the absolute count of the WBCs is more than 1,000. It is at 18.20% of the eosinophils. The patient had history of cough, cold for 8 to 10 days, and he turned out to be an asthma case. So in acute asthmatic event also, you can get eosinophil counts, which is slightly on a higher side. But we have to rule out tropical eosinophilia in this case in the Indian context. The next is a interesting slide about the eosinophilia also. Hemoglobin is slightly low, most of like iron deficiency anemia. If you see the WBC count is a gross leukocytosis, predominant eosinophils. Count 59.60 is more than 9,000. More than 9,000, and the count is total count is 15,750. The patient had, well, it was a confirmed case of tropical eosinophilia syndrome, which the patient presented with a history of cough for 1 month, which was especially increasing at night hours, and has taken all the taken treatment, but he never responded. So this is the case, and we have to rule out the helminthic infection also. It's a little better in these cases to give and parasite worms medicine, because it can cause the low hemoglobin can be because of the worms also. So this is an interesting case of higher eosinophil count. So this is again a case where the low hemoglobin count 10.6, and which is associated with lower RBCs, and WBC count of 3,000. The patient is a child who has a history of the known case of thalassemia minus. The hemoglobin is on the lower side, but RDW is 43. And why I'm showing you this slide, because RDW is sometimes mentioned in the percentage forms also. So The RDW in this case is normal, 26.45%. For a 10.6 hemoglobin, is RDW is normal. You have to think about the possibility of hemoglobinopathies, that is thalassemias, etc. This patient is a child who is a confirmed case of thalassemia minor. Both the parents are also thalassemia. One of the parent is thalassemia minor patient, and the child came to me for a viral infection which was there for 5 to 7 days, which is represented by the low WBC count, that is leukopenia you can observe. And again, this is a case of low hemoglobin, that is hemoglobin is 7.1%. Hemoglobin is 7.1%. The total RBC count is 0.29, that is normal. Then mean corpuscular volume is low, 62.5. RDW is 19.4. So this is a clear-cut case of iron deficiency anemia. You can see the morphology which is there: hypochromia, microcytosis, and anocytosis, which is correlated well with the RDW count. Then next slides is hemoglobin is 11.7% with a mild leukocytosis and slightly low platelets. The patient shows predominant lymphoneutrophilia, and the case was considered normal. The patient had a history of urinary tract infection, which has given rise to this mild leukocytosis. The next case is hemoglobin, which is 12.8, and mostly it is because of iron deficiency status, slightly lower than the normal values of 13. But for a male, you should consider that this is a very early or slight anemia. Then the platelets are slightly on the lower side because of the history of viral infection. The next slide again shows presence of low hemoglobin along with 2,900, that is leukopenia, and low platelets. This mild pancytopenia is generally caused sometimes by the acute viral infection. You can see the patient is suffering from viral infection because the count 2,900, that is associated with relative lymphocytosis. So if you see a case of leukopenia along with relative lymphocytosis with a history of fever, two things are possible. Most probably, either this is viral infection or it can be enteric or typhoid fever also. The patient showing signs of iron deficiency anemia. Then next slide, which is there, tells you about the hemoglobin, which is 12.2. Then white cells is showing leukopenia, and hemoglobin is also less. This is a case of malaria. The patient was detected to have P-Vivax. All these, the initial report do not show presence of malarial parasites. The smear which was taken during the chills showed the presence of P-Vivax. Then the next report shows RBC count, which is in excess of 4.82. Hemoglobin is normal with WBC count, which is 12,000 with predominant neutrophils. It is neutrophilic leukocytosis. The patient was found to have urinary tract infection. The next slide shows a normal hemoglobin and with the depressed leukocytes, which is because of the viral infection. Then this is a very interesting case. The hemoglobin is 16.7, which is more than normal average Indians will have, and with other parameters which are perfectly normal. This patient is a chronic smoker, so he tends to have 30 to 40 cigarettes in a day. So this is the reason why the hemoglobin is on a higher side. So if you see a higher hemoglobin in the patient who is otherwise normal, try to rule out smoking, that is chronic smoking, as a precipitating factor. Then this is again a case of anemia, and the hemoglobin is 9.5 with a lower mean corpuscular volume, that is, and slightly raised RDW. The cause seems to be the iron deficiency anemia. This is an interesting case. The patient had a 75-year-old lady. The patient had the history of fever for 7 to 8 days. They have called me for a visit. We have done the basic test. The hemoglobin was 8.1%. Then the RBC count was 2 lakhs, which is pretty low. Packed cell volumes are also 26.9. Then the mean corpuscular volume was tremendously high, 134.5. Then the mean corpuscular hemoglobin was slightly raised, 40.5. Mean corpuscular hemoglobin concentration was normal. RDW was slightly raised. And see the leukocyte count. It is a gross leukocytosis. Basically, it's a leukemioid reaction with the predominant lymphocytes. When you see a leukemioid reaction with the predominant lymphocytes, the chances of infections are very less. Most commonly, it is because of the lymphocytic leukemias. And we have done the specific tests. They are called as flow cytometric studies or the advanced CBC, which finds the markers which are present in these WBCs. And these markers which were there, they were found there, and this case was diagnosed as case of chronic lymphoid leukemia. The patient in the hospital, the patient was not given any chemotherapy because the hematologist thought that this is an acute crisis, that is acute on chronic lymphoid leukemia. Any viral infection which triggers the lymphoid lineage or triggers the lymphoid lineage can cause a temporary disruption of the control or the what you call which is the CML, and it can cause a crisis condition where the patient can have a higher base or the leukemia reactions of the lymphocytes. The lymphocytes in the next reports are shown to be decreasing, with the WBC count also decreasing, and there is a myeloproliferation of lymphocytes because of the CLL, chronic lymphoid leukemia, and you can MCV, which is high display caused by the leukemias. This is her report after house after 10 days of discharge. So hemoglobin has recovered to 9.4. The hemoglobin WBC count is 18,910, and the neutrophil is 17.7.9. Are also reducing. The patient is now not on any medicines except some vitamins, and advised to keep the watch on her CBC reports. Then this is another case of iron deficiency anemia. You can see low hemoglobin with a low mean corpuscular volume, and WBC count is okay, 4,500. Platelets are normal. This is a particular case where the hemoglobin white cells hemoglobin is normal, the RBC counts is normal, then the white cell count is 4,000 and the platelets are reduced 89. This why I'm giving this value is because this is a case of early dengue infection. The patient had history of fever for 4 to 5 days, and we have done the test, and the dengue was later confirmed. This is again an interesting case. I've called for a visit to see this lady who is 75-year-old who had history of fever with chills for last 4 to 5 days. We have done the basic studies. The WBC count is 25,000 almost, with predominant neutrophils. When you see predominant neutrophils, although you cannot totally rule out the possibility of leukemic possibility, mostly you have to treat on the terms of infection which has resulted into this leukemioid reaction. The patient was later found to have a bad cystitis and urinary infection, and she responded very well. The count after 2 days was 17,000, and the fever started going down. Then this slide as a measurement of a perfectly normal CBC report in a adult menstruating female. Hemoglobin 12.3, RBC count perfectly normal, packed cell volumes 37.9, mean corpuscular volume 88, mean corpuscular hemoglobin is 28.5, mean corpuscular hemoglobin concentration is also normal, RDW slightly higher, but that is ignorable. Then WBC count is normal and platelet counts are normal. So this is a case of normal CBC report. So I've kept this slide as a last slide. Oh, sorry, what you call penultimate slide. And this is another report where the hemoglobin is 8.7. The cause is most probably, if you see the MCV, it is very low. That is microcytosis, mean hemoglobin, corpuscular hemoglobin is also low. Then RDW is very high. So that practically rules out possibility of thalassemias. So this is most probably an iron deficiency anemia. Morphology of RBCs, as mentioned, are hypochromia, microcytosis, and mild anisocytosis. So this is how we have covered up till now. This is how we have covered up till now the common CBC interpretation and how to interpret the CBC reports. Although I'm very much sorry that I was not able to gather enough reports to show you, which shows the details of all other pathological conditions which can cause disruption in the CBC counts. But this is what I was able to gather in the time limit which I had. Hope this session helped you to understand CBC much better. And with this slide, I prefer to say thank to all of you and to the admin team.
धन्यवाद रजनीश सर.
And just 1 minute, I am again sorry for the disruption in between, because there was that failure of the electricity, and I have to reconnect back to the mobile network, and it was also giving some trouble. So I'm really sorry if there was a problem while streaming of my lecture.
धन्यवाद सर, धन्यवाद. मैं अकोला के वैद्य अरुण राठी सर से निवेदन करता हूं कि वे अपना मत प्रदर्शन इस व्याख्यान के बारे में दें. अरुण राठी सर. राठी सर.
Hello, whether I am audible?
Yes, sir.
Thanks, Dr. Rajneesh. Hello.
Hello.
Hello. I am audible?
Yes, yes.
Thanks, Dr. Rajneesh. It's always pleasure to read your post, to speak with you, to listen on any subject. Your approach is always practical and precise with applied aspects. आज का सेशन में ऐसे बहुत से लोगों को जो आयुर्वेदिक प्रैक्टिस करते हैं, they don't have scientific temperament, they will say okay इसमें तो कोई आयुर्वेद था ही नहीं, ये तो सब जो बातें हैं वो पूरी मॉडर्न के हिसाब से हुई. But it always very going with today's era, where the investigations are of very much need to you. They should be applied with Ayurveda on day-to-day basis, and you have explained this in great detail with a scientific approach. अब बहुत से लोग ये कहेंगे कि भाई इसमें तो आयुर्वेद था ही नहीं. In the fever, in starting, you have given one very good note for strotas. Strotas are dynamic. Anatomical marking of strotas is not possible at every time. So regarding the practice of Ayurveda, one should be very keen and precise for reporting and all these things. You can find many hetus. आपको हेतु मिलेंगे इसमें. चिकित्सा के लिए एक आपको प्रणाली मिलेगी कि हमें कौन सा द्रव्य कहाँ और कैसे यूज करना है. So it was very nice to listen you. Thank you. Hello.
Yes, sir. Yes.
Thanks a lot.
Okay, thank you, sir.
और एक चीज मैं विशेषता कहना चाहूंगा रजनीश जी के बारे में कि जो गलती उनकी नहीं थी, electricity failure was not in his hand, but again he has regretted for it. It explains Vidya Vinayena Shobhyate. व्यक्ति को नॉलेज आने के बाद में, किसी मुकाम पर पहुंचने के बाद में उसने विनयशील रहना ही चाहिए. हैट्स ऑफ टू यू डॉक्टर रजनीश.
धन्यवाद सर, धन्यवाद सर. आप लोगों ने जो मुझे मौका दिया उसके लिए मैं बहुत आभारी हूँ आप सभी लोगों का.
नहीं नहीं नहीं, आपको सुनना हमेशा एक गौरवपूर्ण बात रहती है. यू आर अ फ्यू पर्सन इन आयुर्वेदा वर्ल्ड विथ अ साइंटिफिक टेम्परामेंट. And it's always very delightful to have you on any stage, to speak with you, to listen to you. Your approach is always very scientific. Thanks a lot for giving such lecture and fine points regarding CBC.
थैंक यू सर. हमारे साथ श्रीकांत वाघ सर है. अगर वाघ सर कुछ अपना मत प्रदर्शन करना चाहे तो मैं उनको निवेदन करता हूं कि वे अपना मत प्रदर्शन करें. वाघ सर, या और भी कोई श्रोता अपने प्रश्न पूछना चाहते हैं तो वे अपने प्रश्न पूछ सकते हैं.
संदीप सर, एक चॅट बॉक्स मध्ये कोमल
हो.
मॅडमचा एक
वाचतोय सर. रजनीश सर, एक प्रश्न है.
हेलो.
हाँ सर,
हाँ.
एक प्रश्न है आपके लिए.
हाँ, बोलो सर.
You spoke about high HB in a smoker. I would like to ask about a patient. HB was 16.5. Absolute eosinophilia, having whooping cough every year in the month of December, but reduced significantly with woman every year in Vasant Rutu. But
See, I'll tell you one thing. I've given you the example of chronic smokers, but chronic lung disease also tend to have higher level of hemoglobin. Hemoglobin levels are as a response to the oxygen requirement. मिलिंद पाटिल सर ने पहले ही लेक्चर में जिक्र किया था, that is hemoglobin hypoxia induced growth factor, that is HGIF करके एक चीज का उन्होंने वर्णन किया था जिसके लिए नोबेल मिला था. तो ये जो हाइपोक्सिया इंड्यूस ग्रोथ फैक्टर और स्टिमुलेटिंग फैक्टर जो रहता है ना, when the person is exposed to hypoxia, either chronic lung disease and similar, if the person is working in a industry where is continuously exposed to carbon dioxide or carbon monoxide, especially in the bakery, or if the person is living in higher altitudes where the oxygen concentration of the ambient air is less, or his person is suffering from chronic pulmonary diseases, this fellow which is having a regular cough and cold, especially a seasonal cough and cold, generally they tend to have a higher hemoglobin levels as a response to the chronic hypoxemic stimulus. And it is already mentioned in the pathology textbook. That can be the reason in this person having higher levels of hemoglobin. And the person, as you said, he's having higher levels of eosinophils. So higher levels of eosinophils, if they are not very exorbitantly high, they are always in allergic disorders such as asthma. Then are seen in the tropical eosinophilia syndromes. So you are perfectly right when you say that the person is suffering from cough, cold, seasonal exacerbation of his infections, and he's having higher hemoglobin levels, because lung disorders, if they are chronic, they can cause higher levels of hemoglobin. Hello.
Hello.
Hope I'm able to clear your doubt, sir.
Yeah, she said thanks.
Yes.
All participants are unmuted now, so they can ask the question directly.
Hello, I'm Dr. Shrikant Wal. I just wanted to add something. That something means two things. One thing is methotrexate, which is used in rheumatoid arthritis very commonly, is known to cause leukopenia. And
I'm not hearing you properly, sir. The voice seems to be a little bit on the lower side.
Methotrexate. Hello.
Hello.
Now
Is it
it's
all right
clear.
now?
Now it's clear.
Oh. Methotrexate, which is commonly used in rheumatology practice, leads to leukopenia. And you mentioned only about leflunomide. So I thought that methotrexate is the more important cause which we observe in the day-to-day rheumatology practice.
See,
And then second small rectification is rituximab is not so commonly used as you mentioned in acute rheumatoid arthritis. It is methotrexate and leflunomide, and now there are other drugs also like tocilizumab, which are available. They are used in they are more used in most of the rheumatoid arthritis patients. Rituximab is expensive drug, and it is not uh, used so commonly in our day-to-day practice. So these are the two things which I wanted to mention. But it was a nice lecture, enlightening so many new things. Routine thing. But I would have liked to have your views on Raktavasrotas, especially the what we call as how to link these with maybe a few additions about our knowledge of Pandu and our knowledge of Kamala. I think that would have added uh, 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 added some good information for us. Maybe you can write on our WhatsApp group about these things. That how do we relate these things with number one is Raktavasrotas, number two is Pandu, and number three is Kamala. So that would have been useful addition to this lecture. But anyway, the lecture was very nice, and thank you so much for a very nice lecture.
yeah, I'd just like to say that methotrexate I have included in the drugs which can cause leukopenias, but I've gone through the slides very fast because there are a lot of number of drugs which can cause leukopenias, but it has been mentioned. And methotrexate not only cause leukopenias, it can cause aplastic anemias also.
Yes.
And yeah, so methotrexate and rituximab, I have told, because most of the time patient gives history. Most of the time to people like us who are doing Ayurvedic practice, the people comes with the chronic ailments. Suppose a person who comes to you who is already taking rheumatoid treatment and he has seen a good rheumatologist at Ambani hospital or any other hospital, and he says मेरे को एक महंगा इंजेक्शन चालू है और उसका ये चालू है. So just to inform the people or the doctors who are present on this discussion, I have mentioned the name of rituximab because the person who is suffering from this thing, leukopenias, the drug which is given in this hospital can be the injections which is costly and which is given, it generally rituximab. Just to inform to the viewers, I have included the name, sir. And regarding the correlation, Ayurvedic correlation with the modern aspects, it's a topic of another lecture, which which I will discuss with Dongre sir and other senior stalwarts like you, sir, and we'll finalize something about that, but in the due course of time, sir. Hello? Hello?
Yes, sir. Yes.
Yes.
डोंगरे
Hello.
सर.
Hello.
Yes, sir. बोला.
Rituximab is given usually once in 9 months or so, and it is given as 2 doses, one after another, means first dose and second dose after 15 days. So if that patient is taking something regularly, a costly injection regularly, that is likely to be adalimumab and not rituximab. So, but it's all right. Adalimumab is now easily available since last 2 years or so. It costs much less than rituximab. Anyway, that's all right. I think it is a different discussion. Thank you.
Thank you, sir.
संदीप जी, मेरे एक दो सवाल पूछना चाहता हूं मैं.
हाँ सर, बोलिए.
एक पहली बात तो ये है कि पूरे इंग्लिश में ये जब से हमने ये कार्यक्रम शुरू किया तभी से पूरे इंग्लिश में ये पहला व्याख्यान हुआ है और विषय को लेके. इसके लिए मैं रजनी जी को अलग से धन्यवाद देता हूँ, क्योंकि ऐसा भी न हो कि हम लोग कोई अन्य भाषा में बात ही नहीं कर पाते, खास करके अंग्रेजी में बात ही नहीं कर सकते, ऐसा न हो, इसके लिए मैं उनको धन्यवाद देता हूँ. My first question is very basic question related to overall, but particularly related to CBC, is what are the prior conditions of the patients to go for the CBC test? Second, how many times and when the repeat CBC should be done? And third question is, particularly there is one section in Vaidyas, those who are reluctant to go for any kind of pathological or imaging test. In your opinion, what are the possible errors they can make while conducting or while diagnosing the patient as well as giving the treatment to the patient? Over.
Sir, you don't require to, there is no preconditioning of to do a CBC report. You can do it at 12 o'clock at night also, in the morning also, in the afternoon also. So CBC does not require fasting. It's a generally an estimation of the circulating blood which is into your vessels. So CBC does not require fasting. Again, I'm telling you, you can directly send a patient at night also. If you are suspecting tropical eosinophilia, you have, or the patient of malaria, you have to send for the blood smears or the CBC counts when the person is symptomatic. So there is nothing like a preconditioning. You can send a patient, and repeat CBC is what you want to, what you're suspecting and what pathological condition you're suspecting. That on that repeat CBC is advised. Suppose if the person is suffering from dengue viral infection and the platelets are around 70,000, 60,000, then the question arises whether you want to keep the patient in the house or whether you want to send him to a hair center. And you have, for that purpose, you may have to repeat the CBC on a daily basis, because particularly in dengue and in bad malarias, the person can have 70,000 platelets count today, tomorrow they may fall back to 45,000, next day they may become 20,000. So this is unpredictable. For that purpose, CBC is required almost on a daily basis. Suppose a person comes to you with a hemoglobin of around 9%, which you find that it is a iron deficiency anemia, you give some medicine to increase his iron contents, then you can repeat the CBC after a month also. And suppose the CBC is depressed because of the drug use, I generally recommend to repeat the CBC after 7 days of discontinuation of the medicine. So it is a highly flexible phenomena for this purpose. And the third question you ask is that what is the drawback of not recommending pathological investigation if you are practicing pure Ayurveda? See, as Acharya Charak has mentioned, Jnana Buddhi Pradipena Yona Vishati Yogavit, आतुरस्य अंतरात्मानं सनरोगान् चिकित्सिति. And what is yoga with, and what is jnana buddhi pradipena, and what is your aturasya antaratmanam? Aturasya antaratmanam, Chakrapani Maharaj has mentioned and commented on this particular word as rugnasya antar shariram iti vaidya pakshe. It is not that like a yogi are supposed to enter into the mind or atma of that particular patient. You have to enter like a yogi, how your yogi enters into the another person's body. You have to enter into the another person's antar shariram, which is a part, the Rakta Dhatu is part of that antar shariram. And if this pathological test or any test which helps you in to know in detail about the antar shariram of a patient, then they should not be discarded, or they are not considered to be something like heretic thing to be done if you are, even if you are practicing Ayurvedic thing. See, mild anemia, as I've told you, 10.5, 9.5, you will easily miss. There is no test which can clinically tell you that the patient is slightly pale. The way you start noticing the anemic features when the hemoglobin starts falling below 8, 7, etc. And by that time, the patient has suffered a lot. So if you write in this scenario, simple CBC, it will help you to understand that the patient is suffering from Pandu, and you will be able to treat the thing at the earliest. The Kriya Kalam Nahape things occurs here. So I am of a view that you should be able to interpret the pathological test, maybe in Ayurvedic context, even if you are doing Ayurvedic, pure Ayurvedic practice. Hope this clarifies the whole thing.
Okay, thank you very much.
रजनीश सर, और एक प्रश्न है. Is there any difference in pathology between hypoxia and happy hypoxia? If not, what is the cause of hypoxia being happy?
See, that is the appreciation. See, generally, happy hypoxia is the term which has come after the COVID infection only. Previous to that, nobody has heard about happy hypoxia. And happy hypoxia is generally not associated with CBC derangements. What happens? There is the blood is destroyed in the acute phase of COVID. So the small capillaries into the lungs, they are choked with hemoglobin, and they are choked because of the destruction of RBCs. And what happens in those cases, and the brain is also affected. See, when you are deprived of oxygen, you just close your nose and mouth for a 1 minute, you will come to know how the brain reacts to that particular phenomena. But if the brain do not receive the information from the body that the body is receiving, because the virus affects the brain centers also, receiving less amount of oxygen, even if you are breathless, you are not aware of that breathlessness. So that is called as happy hypoxemia. And that is the reason most of the people become serious without noticing that they are becoming serious in the acute COVID crisis. Hello?
Yes, sir. Thank you.
Yes.
और भी कोई प्रश्न पूछना चाहते हैं? डोंगरे सर.
हॅलो.
हाँ सर, नवीन प्रश्न नाही आहेत.
बरोबर, ठीक है. फिर अगर किसी को और कुछ पूछना नहीं है, हाँ बोलिए सर.
नहीं सर, कोई नहीं है नया.
ठीक है, अगर कोई किसी को प्रश्न है तो आप ग्रुप पे पूछ सकते हैं. आफ्टरनून को अगर मेरे को अगर पॉसिबल है तो मैं उसका जवाब देने की कोशिश करेगा.
डोंगरे सर, आभार.
धन्यवाद वैद्य रजनीश जी गाड़ी जी. और इस तरह से कार्यक्रम को संपन्न करने के लिए जो आज के संयोजक संदीप उबाली जी, उनका भी मैं धन्यवाद देता हूं. उसी के साथ साथ इंस्टीट्यूट ऑफ आयुर्वेद के वैद्य विलोप जी है, उनको भी धन्यवाद देता हूं. और सारे श्रोतागण जो धीरे धीरे करके संख्या में बढ़ रहे हैं, ऐसे मुझे लग रहा है, उनको भी खास धन्यवाद देता हूं. और इसी तरह आज का ये सेशन समाप्त होता है, इस तरह की घोषणा करता हूं। धन्यवाद।
धन्यवाद सभी को।